Good morning, students. I am going to voice over this chapter for the pediatric, which in your red book is chapter 13. There are parts of this chapter that I'm not going to be going over, so I'm just going to touch on some key parts to it. When you think about pediatric, kids developing or having issues with neurological function, it could run a variety of things from infants all the way up to kids. So the kind of like the age group is pretty significantly big. Okay, so cranial nerves. Your book does go over all the cranial nerves, the spinal nerves, talks a little bit about CNS, PNS, ventricles, meninges, and reflexes. So when you have a newborn, if they don't have those natural reflexes that we learned about last semester at birth, Moro, sucking reflex, there's so many of them that you would definitely want to investigate. They should have a Babinski sign. It's positive Babinski. When you stroke the foot, the toes fan out and go upward. This does disappear by the age of 9 to 12 months, so that's normal at birth. Rooting reflex, stepping reflex, all of those reflexes should be present in newborns. So if they're not, then that kind of gives us some indication we need to look into things a little bit further. Okay, and then, again, a lot of what we look at with kids is developmental. Do they have a normal growth and development? We measure them, we weigh them, we kind of assess every time we see a child in the doctor's office, because they go to the pediatrician several times their first year. And we're looking at those milestones to see if we're having this growth and development. Remember, when children have issues with neurological or cardiac or any of those things, we often see it in their growth and development. We also want to teach parents what to expect. We want to go through some of the history to see if we're having some concerns about a child. Then we want to say, okay, does this correlate with the prenatal and the birth history, or even after birth? Did something happen during birth that could cause a deficit? You think of things like cerebral palsy, a myelomeningocele, or spina bifida. These all happen, in utero, and then we see them post-birth, right? So these are things that we want to be looking for. So a couple of diagnostic procedures that we can do on kids and babies, if they're having issues. We can do a lumbar puncture on a child, just like we do on an adult, to look at the fluid, to see if it's cloudy, to see if we have any concerns, and we analyze it in the lab. We can also do something called a subdural tap, removing fluid in the subdural space. This can also be caused by disease or trauma to the head, especially in infants. The procedure can be, we actually can insert a fine hollow needle through the fontanelle or the suture area of the skull, and we can look at that fluid. Sometimes this has to be done to relieve intracranial pressure. And remember, we always are looking for increases in intracranial pressure. So that's something that we need to be aware of all the time, signs and symptoms of that. And then in EEG, we can do this on children too. It's pretty much non-invasive, really. You're just putting electrodes on the outside of the scalp, and then we might show them bright lights or pictures or noises and see if we have electrical activity changes. Okay, so that's another procedure. CTs can be done. We do CTs on adults, and we also can do them on children. We can look at different sections of the brain, looking for tumors, abnormalities, ventricle size. MRI also is useful. And then transillumination, this is a different test that we could do where we use a light to shine on the body cavity. We have to do it in a dark room. A bright light is shined on the body part to see if we can see, like in this case, some abnormal fluid on the skull. Other things are, of course, looking at the CSF, like we can look for levels of protein, look for infection, look for glucose, electrolytes, blood work. We can do liver functions, blood cultures, and drug titers. These are all some possibilities if we're, we have, you think of all the different things that could be going wrong, hydrocephalus, seizure activity, brain trauma, tumors. We can look at the lab work to correlate with our diagnosis. Again, when it comes to behavior, kids do exhibit a specific behavior in some of the diagnosis, right? So high-pitched shrill of a cry and things like that. So when we want to be looking always at, asking parents about how is their personality, how is their behavior, are they interacting like a normal baby at that age or a normal toddler at that age, right? Muscle function is important because we want to see if we have abnormal movements in gait. And, they're not able to do the normal physical activities that they would be doing. And then sensory, do they have any problem with discrimination of touch or sensation? So that's what we're looking for. So one of the first diseases we'll talk about is hydrocephalus. This is a buildup of fluid in the cavities or the ventricles in the brain. And this excess fluid will actually push out and put pressure on the brain itself, and also be able to, and the skull size will actually enlarge. So they'll have an enlarged head. With babies, they have these fontanelles, which means and the suture lines, which means that they have the ability for their head to actually stretch like this. It doesn't look pretty, however, and it's very scary for parents. And it does show that there's something going on with the ventricles of the brain. And this is what's happening inside the brain here. Increased volume of the normal amount of cerebrospinal fluid. And this also puts pressure on the cranial cavity or the brain itself. So there's a couple different types of hydrocephaly. One is called communicating and one is called non-communicating. And the difference is really the type of a blockage or obstruction. So when it's located within the subarachnoid space, it's called communicating. And then when it's non-communicating, the blockage is within the vessel, its ventricles itself. And the fluid is just kind of building and building and building inside those ventricles. Pathology, 3 possible mechanisms. Too much production of CSF. So there's, the fluid is excessive, defective absorption of the fluid itself, or an obstruction of the CSF. And those, the obstruction can be either from inflammation, congenital malformations of the brain, or tumors itself. So we have to find out what is causing the hydrocephaly. So if there's hydrocephaly, we have to look into it and figure it out. Signs and symptoms. So this, again, might be on a test question. What are the signs and symptoms? Well, this is putting fluid pressure on the brain. So we might see a bulging fontanelle. Okay, we might see the scalp becomes very thin, and you see the veins on this child, the one that's lying down. The veins will dilate on the scalp and the skull. The cranial suture lines start to separate a little bit. And then some other clinical symptoms on the bottom, like this child with the bulging eyes. We also call it sunset eyes. And then vomiting, nausea, vomiting, wide bridge between the eyes. And that one, really, these two pictures are not pretty to look at. In the severe form, where child, the head size is growing pretty fast, the child can have this horrible shrill and high-pitched cry, and it's pretty horrible to hear. They also have some irritability and restlessness. And then older children don't get a head enlargement, but they have other things like papilledema, ataxia, so their gait is off, altered mental status, strabismus of the eyes, headaches, ataxic gait. I mean, these are things that are significant. So we want to be, looking at these and looking for the signs and symptoms. And these can be very difficult for parents. So treatment, what do? Well, we want to lower the amount of fluid inside those ventricles because we want to put less pressure on the brain and we want to relieve symptoms. So we would put in what we call a VP shunt, ventriculoperitoneal shunt, and it gets inserted with a video camera, just like this picture. They put the shunt in, and the shunt actually will go through into a vein and then down into the peritoneum. It'll travel from the brain down into the peritoneum. And in this cavity, the fluid will drain into the peritoneum, which could be easily absorbed, okay? So they place the shunt, and then they'll have a little valve behind the ear, so it'll come out. I don't think it goes into a vein. I'm sorry, not a vein. It travels from the brain in through the skin into the cavity of the peritoneum. That will definitely relieve the pressure inside the cavity, the ventricle. So this is very helpful. You have to still monitor the child, and the parents will be taught to do some daily head circumferences, heights and weights, and looking at the fontanelles, looking at the behavior patterns of the child. And then, is there any vomiting? Are they able to eat? Are they able to, gain weight? So those are some things that they would be monitoring. Your book does have some good stuff about hydrocephaly. So, and it actually, I just don't remember which page it's on, but talks about care of the shunt and catheter. On page 266, there's some symptoms of a shunt infection, home care and management of the shunt. So making sure parents are given lots of education about how to take care of it after. The pre-op and the post-op care. Mainly it's about teaching the child, positioning. Well, the big thing about babies having anything like that is we still want parents to hold and cuddle their babies, and we don't want them to have any reason not to. But nausea, vomiting, headache, irritability, lethargy, fever, these are things that they'll be monitoring after. So you can take a look at that. Again, nursing care, good neuro assessments, positioning is important, good skin care, neck care, positioning. And then there's more here. Observing the shunt, looking for infection, abdominal girth, checking the abdominal girth. Remember that increased ICP, the first signs and symptoms are always like lethargy or change in mental status, right? In a child, we're going to have to be very aware of their normal patterns. So when we see change